This is a synthesis on the effect of constraint-induced movement therapy on patients with stroke. Background: constraint-induced movement therapy consists of rehabilitation techniques in order to overcome upper limb impairments after stroke. It is based on the theory of learned non-use, which develops as the patient begins to compensate for difficulty using the impaired limb by increasing reliance on the intact limb. CIMT is then applied with the hypothesis that earlier intervention may precede learned non-use from developing. Overview of searching conducted. The databases that were used were EBSCO Host and Stroke Rehabilitation Online, which is found in Google Books. The first article that was identified was on the effect of constraint-induced movement therapy on upper extremity function 3 to 9 months after stroke. This was a study done in the year 2006 by Wolf et al. The second study that was conducted was on the effectiveness of constraint-induced movement therapy in chronic stroke patients. This was a study done in the year 2004 by Suputi-Tada et al. The third article that was used was on the effectiveness of constraint-induced movement therapy as a home-based therapy on Barthel Index in patients with chronic stroke. This was a study done in the year 2009 by Azab et al. Lastly, the effects of constraint-induced movement therapy on patients with chronic motor deficits after stroke was used. This was a study done in the year 1999 by Miltner et al. Overview of the methodology. The study design that was used was a controlled trial, which is composed of a control group and an experimental group. The experimental group was given CIMT as an intervention. The first study was composed of 222 individuals with first-time clinical ischemic or hemorrhagic cerebrovascular accident who were predominantly ischemic. The second study was composed of 69 chronic stroke patients. The third study was composed of 27 participants in the experimental group, 16 of which were men and 4 women. 17 participants were found in the control group, 12 of which were men and 5 women. The fourth study was composed of patients with chronic motor deficit after stroke, 9 of which had right hemiparesis and 6 had left hemiparesis. Data gathering procedures. The data gathering procedure for the first article was done by taking a baseline prior to provision of CIMT with follow-ups for 8 and 12 months post-treatment. The sample was divided into 2 groups with 106 receiving CIMT and 116 receiving usual and customary care. The study conducted was a prospective, randomized, observer-blinded clinical trial. The study utilizes 2 groups as well, 33 receiving CIMT and 36 receiving conservative treatment. For the third study, the data was initially gathered with a pre-test. Afterwards, a follow-up was conducted. This also utilized initial evaluation and re-evaluation done in 6-month intervals. In the last study, the researchers had made first contact and had taken the participants' baseline data. Pre-treatment and post-treatment were also utilized, and after 4 weeks post-treatment, data was gathered yet again with follow-ups thereafter. The statistical test that was used for the first study was the SAS version 9.1. It had a p-value of 0.01. The statistical analysis for the second study comprises of the chi-square test, Wilcoxon-Signed rank test, Mann-Whitney U test, all of which had a p-value of 0.05. For the third study, an unpaired t-test and a chi-square test was used. It had a value of 0.05. In the fourth study, repeated measures ANOVA and paired t-tests were used. It had a p-value of 0.0001 and 0.0002 respectively. Overview of the results of the articles. For the first study, among patients who had a stroke within the previous 3 to 9 months, CIMT produced statistically significant and clinically relevant improvements in arm motor function that persisted for at least 1 year based on the better outcome scores of the WMFT and MAL. For the second study, the ARIS scores of pinch strength of the affected upper extremities were significantly higher in the CIMT group in comparison to that of the control group at a p-value less than 0.05, but the test results for hand grip strength was not statistically significant at the p-value of greater than 0.05. The third study showed that chronic patients showed statistically significant improvement in the Barthel Index in the experimental group compared to the control group. After 6 months of follow-up, Barthel Index indicated that the gains were maintained at 6 months post-discharge compared to their Barthel Index score at 4 weeks post-CIMT. Lastly, for the fourth study, patients showed a significant degree of improvement on a laboratory motor test and on a test assessing amount of use of the affective extremity in activities of daily living in life setting, with no decrement in performance at 6 months follow-up. During a pre-treatment controlled test-retest interval, there were no significant changes on these tests. Conclusion. In conclusion, based on all 4 studies, the use of constraint-induced movement therapy as an intervention is effective in patients with stroke, as evidenced by overall improvement in Wolf Motor Function Test, Motor Activity Log, Action Research, ARM Test, Hand Grip Strength, Pitch Strength, and Performance in ADL, which was measured using Barthel Index. Thank you for watching.